have the last talk of the session, and that is by Dr. Chaitra Jayadev, presenting her data on Oceva.
Thank you very much, sir. It's our data, our experience. It's not a single center. We did it across 5 centers just to get a quick idea of whether this drug works well across a few indications. Okay, my slides are not moving. Slides are not moving. Okay, so this was the Oceva study group. We had Dr. LV leading from CFS. We had Dr. Manisha, Dr. Rupa Kanti Viswas, Dr. Divyansh, and myself. We put together data and no financial disclosures just to get a idea of how this drug works for us. This is the study which actually showed us how many injections are recommended for the patient and why they don't take it. Most of them don't take it either because of the repeatability of the treatment required and also because of the cost involved. So yes, there is a mismatch between what is recommended and what happens in real life. And like I mentioned, cost is the biggest factor. Now, this is the study that looked at a 6-year analysis of the impact of anti-VEGF treatment and the patient characteristics on vision outcome. Here, with that cohort of a very large number, with the first anti-VEGF injection and at least 2 years of follow-up, they brought out the visual acuity data. And if you can see here, after modest mean visual improvement with intravitreal anti-VEGF at year 1, patients netted a loss of visual acuity by year 6, which means they really need to keep taking injections till that time because there's a fallout. Injection frequency eventually decreased over time, and this was paired with a relatively high rate of discontinuation, which is probably the reason again why there's a drop. And the modeling suggested that more frequent injections were associated with better visual acuity outcomes. But unfortunately, again, affordability and compliance becomes an issue. And there was difficulty with continuous adherence to frequent intravitreal injections that may have contributed to under-treatment and therefore less optimal visual outcomes. So this is almost a 6-year follow-up, which means that even at 6th year, we tend to tell the patient by the 3rd or 4th year, the number of injections required comes down, but apparently not from this particular study. So why is there a need for biosimilars? Because the innovator molecule, though extremely efficacious, it is not affordable for many patients in developing countries or a country like ours, simply because of access to healthcare is less. Private insurance is not affordable for all. So biosimilars have made this treatment more affordable. We have many biosimilars at our disposal. Let's quickly look at the cost comparison between biosimilars and innovators. If you see here, there's something called as cost of injection to the patient, to the doctor and to the patient. To the patient, we need to add a whole lot of other things like consultation, their travel, their OCT, etc. So when you look at the yearly cost of the drug, depending on 5 to 7 injections probably, you can see that the cost difference is quite significant between the innovator and the biosimilar. And then when you add the travel cost to it, it becomes exponentially more. So these are the numbers that we need to keep in mind when we are advising injections for our patients, especially because at tertiary referral centers, we do get patients from out of town, and sometimes their travel cost tends to be more than the drug cost itself. Now, coming next to the reduction that we see when we use a biosimilar over an innovator, it's at least 40%. So that advantage the patient should be given because of the number of injections involved. So the era of biosimilars is here. They have comparable efficacy, safety, and duration of action. The production is cost effective because they are manufactured locally. They don't need to be imported. And this has also led to their worldwide acceptance, as mentioned in the previous talks, of the different biosimilars that are available even outside the country. Now, this is an important Cochrane review that will come up soon. It's still in process. They're looking at the anti-VEGF biosimilars for macular degeneration. This has been started in 2023, and this is how they're going to go about it, the different studies, the participants, the interventions, and the outcome measures. So to quickly tell you the outcomes expected, they're going to look at the change from baseline from 8 to 12 weeks with the biosimilars. They're looking at the proportion of of participants who lost vision, and again the composite scores of visual quality indices, the proportion of participants who had serious ocular events, who required treatment, the adverse drug effects, all of this. So this is going to be an extremely important and comprehensive review which is in process and awaited. So now let's look closer home, insights into the VRSI survey on biosimilars that was conducted. You can see here the price points were discussed in this survey, which is important, and also the graph shows the willingness to pay price of biosimilars as what we perceive as the caregivers. We also saw changing in trends in the use of anti-VEGF amongst our peers. A lot of them were, similar compared to the respondents. So we will see here that the majority of the respondents actually believe that biosimilars have made anti-VEGF treatment more affordable. So these are the different biosimilars. I think except for Optimab, almost all the others are available. Currently, Optimab is not there for use, and you also have few FDA-approved biosimilars as well. Now coming to the drug in question, Oceva, this is an Indian biosimilar. It has completed its phase 3 and it's been approved as of April 2022 by the Central Drug Standard Control Organization. Now coming to our experience, we wanted to look at the safety and efficacy of Oceva in maculopathy secondary to common retinal pathologies that we see in our practice. The study period was between July 2022 and September 23 because we wanted to have a good follow-up on these patients. Both treatment-naive and pre-treated patients who received at least one injection were seen for at least one follow-up to see the response. Commonly used conditions such as DME, CNVM and RVO were included. We looked at the visual acuity outcome and the central macular thickness determined before injection and at 4 weeks post-injection, and any intraocular information if noted. So this was the demographics, the mean age in years. And for the diagnosis, we had a maximum patients with DME and followed by RVO patients here. Others, we had, a couple of cases we couldn't analyze too well. This was for PCV, pseudophakic CME, and radiation retinopathy associated CME as well. So the average number of injections received in these patients was 1.3 with a maximum of 121 patients receiving at least one, and then we had 2 and 3 and 4 injections as well. Now, if you look at it, we had more than 50% of patients improving. We had some of them being stable and some of them actually worsened. This was mostly associated with their systemic condition as well. If you see in this CMT as well, at least 70% of them had pretty good improvement, and some of them also deteriorated, which is about 9 patients in this whole cohort. So yes, it was efficacious, improved and maintained in at least 88% of the patients, and close to 90% of the patients had a reduction in their CMT or maintained. It was effective in all subsets analyzed in the data, including the conditions that I mentioned. And the BCVA improved in or maintained post-second injection also in a fair number of patients. We did not have any intraocular inflammation, endophthalmitis, optic atrophy, or any of these that we have seen, with new anti-VEGFs, and we did find it to be a rather safe drug. So I'm going to skip the cases because we have quite a few of them, and I think we're almost time here. Just passing through, you can see the improvement in vision with this particular molecule that we've used. I'll just run through the slides. You can see even large edemas like this, we saw good response. Here again, subretinal fluid and intraretinal fluid has started showing response here. Couple of other cases. Just to show you the intraspectrum, this patient even had an ERM, but good response. They're just some of the cases that we have. So just want to tell you that Oceva is safe and efficacious. It is a good alternative to innovator molecules that we have. It makes it available to all because of its affordability, visual outcomes, and an accepted safety profile. Makes it a good option for our patients in our countries. Thank you so much. This is something that probably give you confidence. Close to 25,000 vials have been used so far, and there have been no major concerns. Thank you.
Thank you, Dr. Chaitra. See, one of the main concerns about biosimilar or to that matter, any new drug is you're worried about the intraocular inflammation and the possible side effects. So when you're starting a new drug, how would you, in your practice, how would you set up the evaluation process to make sure that you don't end up in trouble?
So any obvious, telltale signs of inflammation, we do address that first if there is. And for most others, if you will ask me what's your drug of choice, even if there is some minor amount of inflammation, we really don't have an option because most of them are insured by central or state government agencies wherein only a biosimilar is approved. They do not have access to innovator molecules. In fact, one of the agencies even sends us a note back saying use 3 injections of the biosimilar and only then send for an innovator molecule. So that is one limitation that we have currently, at least in our state. I don't know about the other states. But if there is a frank inflammation, I would be skeptical because we have seen flare-up of inflammations. And of late, since Dr. Padma spoke as well, we've had young patients after the first injection of biosimilars, the inflammation, new onset inflammation coming in as well. So to the point that, we do get recommended by the UVA department to avoid it in certain conditions.
Just one point I just kind of wanted to add over here. Some of the new drugs which actually produce intraocular inflammation, without regular follow-ups of seeing the patient after 1 month, you might miss subtle anterior chamber reactions that happen in the first week or 2 weeks. So when I would suggest that whenever you're using a new molecule for the first time, you probably have to do even a thorough slit lamp examination to check whether there are anterior chamber reaction, because it may not affect you the first time, but the second time you give the drug, you might end up in a massive intraocular inflammation. Doctor?
No, that's where the monitoring committees come into play, because so that the benefit of doubt is spread, the word is spread to the rest of the community. So VRSA does have drug adverse event monitoring like a committee, and you have a form in which, if in case you notice an inflammation after using a biosimilar, if you can fill it up, then the news gets spread faster, so that people probably are much more careful when they use it. I'm sure R&D Ophthalmic Society also has one, so I would suggest all of us use that. Another thing is even with brolucizumab, there are papers where they have given this along with the subtenon steroid, so that has decreased the incidence of inflammation quite significantly. So there is a Japanese paper where in every patient where they have given brolucizumab, they have given a subtenon steroid and found that there was hardly any inflammation at all. That's another thing which can be considered as well.
A lot of this inflammation also tends to subside with just topicals. There are few reports itself which have said that they've needed a systemic intervention. Most of them tend to subside with just topical steroids.
Another major advantage of biosimilars is it has allowed us to move away from using bevacizumab, which has put us in some kind of medico-legally unstable territory.
Because it's a non-approved.
I want to ask, sir, how will you differentiate between this post-injection inflammation and post-injection endophthalmitis when the patient presents to us?
The post-injection inflammation, there are markers, but cannot be an 100% surety. The post-inflammation inflammation, usually the patient doesn't have pain. There is no lid edema. There is no circumcorneal congestion. There's no conjunctival congestion. So these are signs which you can see that actually the eye is quiet, but there is some amount of inflammation in the anterior chamber as well as the vitreous, particularly the vitreous, and the patient complains of decrease in vision. So you can make out the eye is relatively quiet, but then of course you can never assume that it is going to be a post-inflammation. In such a situation, what I would do is to do an anterior chamber tab, send it for a smear culture, as well as probably give an intravitreal antibiotic under steroid in the first instance, and then subsequently follow it up with steroids. But you can make out that the differentiation can reasonably be made out.
Do we have any more questions?
Okay. Great. I think we can call it a day. Thanks everyone for your participation, and thanks to the chair and panelists and speakers. Thank you.